Welcome. Thank you for being here. And I think I'll get started. This is a webinar that's part of our RUNX1 Research Program's Medical Education Webinar Series. And today our webinar is entitled Hereditary Hematologic Malignancies, Not That Rare. I'm Katrine Erickson. I'm the Executive Director of the RUNX1 Research Program, and I'll be your MC for this webinar today. I'm going to start off by saying thank you to our gold sponsor for our medical education webinar series this year, NeoGenomics. They've been wonderful to support this work, and we are incredibly grateful. And actually, before we start the agenda, I just wanted to make sure that for those of you who aren't familiar with the RUNX1 Research Program, that you know a little bit about us. So we're a nonprofit organization. We are dedicated to supporting individuals with RUNX1 familial platelet disorder. And we were started by a RUNX1 family back in December of 2016. And our mission since then has been to improve the quality of life and prevent blood cancers in RUNX1 FPD. And that's because of the fact that individuals with RUNX1 FPD have a 50% lifetime risk of hematologic malignancies. And the most common hematologic malignancy is unfortunately AML. And we all know that that is not a friendly diagnosis. So in addition to hosting medical education webinars like this one, we are also supporting our patient community through education, through research collaboration, and community building. And then we also fund research. And with a number of amazing nonprofit partnerships, we've been able to commit over 13 million in research dollars towards not only understanding this disease, but also in discovering blood cancer preventions. So you can appreciate that a webinar series that covers the underappreciation of the prevalence of germline predispositions to hematologic malignancies is really critical to our mission, but it's also critical to other nonprofit organizations as well, like our sister organizations, Team Telomere, like Fanconi Cancer Foundation and Shwachman-Diamond Syndrome Alliance, et cetera. So we all, as a group, want to be able to diagnose families as early as possible so that preventing the onset of these hematologic malignancies can become a reality in the future. So with that, I will turn it over shortly to our presenter, Dr. Kelly Bolton. She'll present about 30 minutes on this topic, and then we'll be switching into a Q&A discussion with not only Dr. Kelly Bolton, but also with Dr. Sravanti Rangaraju from the University of Alabama and genetic counselor Kelcy Smith-Simmer from the University of Wisconsin. As you're listening to the presentation, please feel free to add your questions to the Q&A icon. And then I'll have a list of questions at the end and we can go through those questions. So without further delay, forgive me for the slide faux pas. I'm delighted to welcome Dr. Kelly Bolton, Assistant Professor of Medicine in the John T. Millikan Department of Medicine, Division of Oncology at the Washington University School of Medicine. Over to you, Kelly.
Yeah, thanks so much, everyone, for attending, and thanks to the organizers for inviting me. And yeah, I thought, I would speak today a little bit about some science behind, our understanding of germline predisposition to heme malignancies and management. I know in the past, a lot of the presentations have been very clinical, really focused on identifying different patients that might be at risk for hereditary hematologic malignancy syndromes. And this slide is taken from Courtney DiNardo's presentation a couple years ago. There's many different genes that have been implicated in hematologic cancer predisposition. A lot of them are relatively less common and confer very high risks of hematologic cancer. And I think we're still in the beginning of really understanding the full spectrum of genes that predispose to hematologic cancer, especially genes that might be more common and less, but with less of a high risk. And a lot of this is because of misinformation, I think, about the relevance of hereditary predisposition to heme malignancies, but also just that it can be more difficult to perform these studies in people with blood cancers. And some of the questions that I'm hoping we can discuss today, and really this is meant to provide fodder for the discussion later, is getting us to think about how we could use an understanding of germline predisposition to prevent hematologic cancers. And so I'd argue that there's 3 essential steps in this if we're just thinking about in the future how we need to conduct studies to better characterize this. First is just really understanding the genes that predispose to hematologic cancer. I showed the slide of genes that Courtney had summarized, but we still have a ways to go. The next is to understand how germline genetic variation influences hematologic cancer development, like the mechanisms of this, and to better characterize the natural history of hematologic cancer. And this will be the focus of part 1 of this presentation. And then in part 2, I'll briefly touch upon how we could use this information to help develop tailored management strategies for germline carriers. So in order to think about how we can use an understanding of germline predisposition to change outcomes in people with heme cancer, I think first we have to remind ourselves that fundamentally cancer is caused by a cell acquiring multiple mutations that occur in successive order over time, and eventually lead the cell to behave abnormally and to become a leukemia stem cell. But we know that from large population-based sequencing studies in healthy people, that you can really detect this process, this stepwise acquisition of mutations in the general population very easily. With age, we acquire mutations in all of our tissues, including stem cells in these normal tissues. And one of the maybe unsurprising things is that the types of genes that you see mutated in different organs are the same genes largely that cause cancer in those organs. And this is because, again, the mutations that lead a stem cell to proliferate are likely the ones that would then eventually lead to cancer. And this is really the best characterized in the blood because blood is so easy to sample. And this is a huge advantage for the germline field in heme malignancies. So we know that when hematopoietic stem cells acquire somatic mutations in certain genes, it can lead to that stem cell gaining a fitness advantage and proliferating more than wild type cells. And this is called clonal hematopoiesis, or CH. So just like mutations in other tissues, this is very common with aging. But importantly, people that have clonal hematopoiesis are at an increased risk of hematologic cancer. But one of the tricky things in terms of if you think about trying to intervene in CH is that actually as we sequence deeper, we actually find that basically everyone has CH by the time, especially by the time you reach middle age, and actually most people have multiple mutations in their bone marrow. So mutation acquisition doesn't seem to be the rate limiting step in people getting cancer. It must be something else, not just the acquisition of mutations. And one thing that we've noticed, and this has been characterized in multiple different settings, is that different CH mutations have different risks of hematologic cancer. So genes like TP53 or IDH confer very high risk of cancer, and genes like DNMT3A or TET2 confer much lower risks. And this has been shown in multiple different populations and multiple different studies. So what are the factors, like why essentially do genes in different genes confer different risks of cancer in people with CH? And it's because those genes have different effects on fitness. And so what am I talking about when I talk about fitness with clonal hematopoiesis? So it's this concept that in a person that has a mutation, a CH mutation, in a gene that confers a low fitness, that mutation might slowly grow over the lifetime of an individual, whereas a gene that confers a high fitness will rapidly expand and maybe even attain dominance in adulthood and has a much higher likelihood of eventually leading to cancer. So this has been shown in prospective studies where they've done longitudinal sampling in the blood of healthy people, that the same genes in general that confer the highest risk of heme cancer are those that grow the fastest over time. So this concept that really fitness is the key feature here in predicting risk of cancer progression holds true. So, but what you might be asking, hey, she's gone on this huge sidebar about clonal hematopoiesis. So what does this have to do with germline genetic variation? So the reason that I bring it up is really because there's two potential ways that germline genetic variation could lead to hematologic cancer. So one is this idea that it could influence CH initiation. So maybe the rate of mutations or the age at which mutations arise. But the other big broad sweep would be influencing mutational fitness. And I argue that I think a lot of the data supports this idea that germline genetic variation, the primary way that it causes cancer is by modifying CH fitness. And so this has been shown in multiple different studies in less common high penetrance hematologic predisposition genes, including work by Abhishek, who's you'll hear from during the panel. But we know that different germline mutation carriers get CH at very young ages, that they have these clonal expanded clones at very young ages, which is very rare. It's very, very rare in the general population to see. And they have mutations in really specific genes. So it might not be the same typical CH genes you see in a middle-aged individual, DNMT3A, TET2. It's specific genes. So for Elaine, for example, you see a lot of CSF3R mutations, RUNX1, you see B-core mutations, among others. And the thought is that why this is happening is because these germline mutations modify the risk or the rate of progression of CH in specific genes because of interactions between the somatic and the germline. But what about in the general population? Like we know that germline genetic variation leads to heme malignancy. And we know that germline genetic variation influences CH, and we know this from GWAS studies. But how and to what extent do the same germline genetic variants that influence CH lead to heme malignancies? And can we use this to better characterize germline predisposition to heme malignancies? And I argue, yes, I think this will be an emerging field and will help clarify more hematologic predisposition genes. And so we took a stab at this as a first approach in the UK Biobank and other large population databases. So, and this work will be out in Nature Genetics in the next couple weeks. So the first goal of our study, which I bring up because I think it does add some clarity about the frequency of germline genetic predisposition to heme malignancies in the general population. So our first goal was to just identify additional genes that predispose to CH and heme malignancies, and to use this to better understand why certain people with germline genetic predisposition genes develop heme malignancies and others don't. So we did this, like I was mentioning before, in the UK Biobank, which is a wonderful resource for people doing studies in heme malignancy or CH. It's a population-based cohort of healthy middle-aged people. In the UK, there's a good amount of follow-up data now, and about 5,000 people in this cohort have developed heme malignancies. And we use several other databases for validation of our findings. So we focused in this paper on less common pathogenic germline variants in known hematologic predisposition genes, because we really wanted to focus on people who had genetic variants that we were more confident about were actually impacting the function of the gene in question. So we found that a large proportion of people harbor a pathogenic variant in a germline predisposition gene for cancer. It's actually about 9%. And the most common two genes, CHEK2 and ATM, were present in about 1.5% of people. So very common to have a cancer predisposition gene in a healthy population. And CH was also relatively common. We're detecting CH here using whole exome sequencing. So we're only able to detect clones that have expanded quite a bit, which is why the proportion of CH is, on the lower side compared to maybe other studies that use targeted sequencing platforms with higher depth. So we wanted to understand, which of these genes or does having a pathogenic variant in a germline predisposition gene for cancer influence the frequency of CH? And we saw that it does, especially for CH driven by copy number events, which I'm abbreviating as MCAs here. And next we wanted to understand, and characterize which genes were driving this increased prevalence of CH among germline carriers. And we found 15 genes that were associated with CH overall, both for copy number CH events and for SNVs and indels. And so you'll notice that a lot of these genes were in Courtney's previous slide of known hematologic predisposition genes, but there's a few that are less well established. CHEK2, like I mentioned before, present in 1% of the general population, conferring a twofold increased risk of CH. ATM, present in 0.5% of the UK Biobank. MIPL, ACB11, which is a gene involved in hepatic metabolism, and CTC1 and BN. These are genes that predispose to heme malignancy in the autosomal recessive setting, but here we're seeing that people with just one deleterious variant have an increased, a modest increased prevalence of CH. So, like I was mentioning before, in people with rare, with less common, Mendelian syndromes, we see that they get very distinct types of CH, likely reflecting fitness pressures. So does that hold true here in more common genes like CHEK2 and ATM? And so we answered this question by just doing pairwise associations between different germline genes and different genes that were acquired, CH genes that were acquired in the somatic setting. And so we saw that, yes, we just like, people see in less common Mendelian predisposition, even in genes like CHEK2 and ATM, you see that certain genes, for example, CHEK2 predisposes to increased risk of DNMT3A and TET2, but actually seems protective against TP53-CH, whereas ATM seems like it's the most strongly associated with JAK2 and with actually a somatic ATM, so probably reflecting a biallelic loss of ATM in these individuals. So if this is driven by selection pressures, then you might say, well, maybe you would see even more associations between germline genetic variants and CH if you look at CH in terms of predisposition to specific genes. So we did this, and we, in the end, identified 55 additional genes that predispose to CH driven by specific somatic events. So overall, this seems to suggest that a lot of germline predisposition to CH is gene specific and probably driven by different influencing the fitness of these somatic events. So if that's true, then we should see that a lot of these genes also increase risk of hematologic cancer, and we did. So a lot of these, like I mentioned before, are known to cause hematologic cancer. Some are less well established, but in the UK Biobank, in this big population, I think we provide very good evidence that they do at least moderately increase the risk of hematologic cancer. And through this, we also identified 4 potential novel hematologic cancer predisposition genes that that we need to validate in additional studies, but are promising leads. So in summary, you know, I found 15 genes that predispose to CH. They were predisposed to specific CH subtypes, and a lot of these genes also increase risk of hematologic cancer, which makes sense since CH is the precursor of hematologic cancer. But, you know, how could this help us to better understand how CH and germline genetic variation interact to develop hematologic malignancies in some individuals? So there's different ways of looking at this. You know, first we just asked, well, if you have a germline predisposition to hematologic cancer, does that interact with CH and influencing your risk of cancer? So we compared the risk of people with a germline predisposition gene only and no CH, people that had CH and no hematologic predisposition, germline predisposition, and people with both. And you can see that there's clearly a multiplicative interaction between having a germline genetic variant that predisposes to hematologic cancer and CH in predicting risk of progression. And that risk varies by germline gene. So genes like KRAS or TP53 or RUNX1, if you have CH, you have very, very high risk of developing hematologic cancer. If you have ATM, or CHEK2, it confers more modest risks. But you know, interestingly, the fact that you can use CH to risk stratify individuals with hematologic cancer is, you know, seen really for most of the germline predisposition genes. So here I'm showing the risk of cancer among people with ETV, RUNX1, all the more common germline predisposition genes for heme cancer. And for some genes, we actually found, like for TP53, that people without CH had basically no risk of hematologic cancer, whereas people with CH had very, very high risks. So, you know, if germline genetic variation is modifying CH fitness, then could we leverage that to better understand and better characterize who has high-risk CH versus low-risk CH? So like I mentioned previously, we know from studies in the general population that TP53 or IDH1 and 2 are generally considered high-risk CH mutations, whereas DNMT3A or TET2 are considered low-risk mutations. But, you know, I showed you previously that, for example, people with CHEK2 germline genetic predisposition, they're more likely to have DNMT3A CH and TET2 CH, but actually less likely to have TP53 CH. So could it be that in a CHEK2 carrier, for example, that's TP53 is actually a low-risk CH gene? And so we answered this question by taking all of our germline carriers and classifying their CH mutations into genes that had evidence of selection. So we saw modest or strong associations between CH and that gene and germline genetic variation. And other CHs, basically, there were CH in genes that showed no evidence of being enriched in the germline carriers. And so we, just reminding you that, for example, in a CHEK2 carrier, DNMT3A and TET2 CH would be germline selected CH, whereas TP53 CH would be other CH or non-selected CH. And so we saw that in general, yes, this idea that genes that were selected for with a certain germline genetic backdrop conferred a much higher risk than CH in genes that were not enriched in germline carriers. And this wasn't driven by, you know, specific germline carriers. It was really seen across different carriers for both lymphoid and myeloid malignancies. And we even saw this, you know, zooming in on CHEK2 carriers, our most common carriers, and DNMT3A-CH, our most common CH gene. We saw that if you had DNMT3A-CH and you had a germline CHEK2 variant pathogenic variant, your risk of getting heme malignancy was much stronger than if you didn't have that germline CHEK2 variant. So again, just I think further providing evidence that even in the general population, the way that germline genetic variation is influencing hematologic cancer risk is through CH largely. So I think this is notable because we found in the UK Biobank that actually 5% of healthy people have a germline predisposition gene for heme malignancies, and that represented 15% of people who developed heme malignancy. So this is a very common phenomena. CH can be used to risk stratify progression to heme carriers, to heme malignancy among germline carriers. And the CH genes that we consider high versus low risk vary by germline genetic makeup. So this implies that that there is really important risk stratification to be gained by doing larger scale germline screening for heme malignancy. So how can we use this understanding that from this work, but really from mountains of other work that have helped us to understand the genes that predispose to heme cancer and the natural history of this. And really, of course, the end goal is to develop tailored management strategies for germline carriers. We're really in the very early stages of understanding this. And a lot of this has been done by my colleagues, including people on the call today, about trying to understand how we can do this. And maybe our first step is to try to figure out who should be screened. And so there's this, I think, and I'll argue that I think all people with hematologic cancer should be screened for germline predisposition. The reason why is because, 15%, at least 15% of patients with heme cancer will have a germline predisposition gene. And this number keeps on growing. Every year, probably it will continue to increase. And germline genetic testing is really cheap. And it's a cost-effective means of identifying an at-risk population. And we know that a lot of the germline heme predisposition genes, especially the common ones like CHEK2 and ATM, they also increase the risk for solid tumors. So that has implications both for the proband and also for the family in terms of their screening for other cancers, even beyond hematologic cancers. And for our patients with heme malignancy, germline predisposition seems like it influences outcomes. And definitely probably the best data for this is in regards to transplant decision making. So it can have implications for the clinical care of our patients. So for example, this is taken from Courtney again. For patients with inherited bone marrow failure syndromes, we know that we have to use reduced intensity regimens. For DDX41 carriers, they seem like they have actually a good prognosis. There's some data that they might be sensitive to lenalidomide, but really we're the best, we have the best data is in terms of just management of transplant decision-making among germline carriers. So we know that donor-derived leukemia can happen after transplant. And this seems to be especially prevalent in germline carriers, especially DDX41 carriers, just because this is a very common gene in individuals with MDS. There's been several case reports on this. I'd say the best or the largest scale so far published work on this in carriers, looking at carrier status and outcomes in transplants, comes from work by Chris Gibson, where they identified that several individuals who go on to develop donor-derived leukemia had DDX41 mutations. In this cohort out of 17,000 people, there were a handful of individuals who developed donor-derived leukemia, and actually 2 of them had germline DDX41 mutations. So clearly this is a risk factor for developing donor-derived leukemia. And so in anyone who you suspect that might have a germline predisposition, to hematologic malignancy, you would want to screen any relatives for that mutation after first testing your proband to make sure that you're not transplanting someone whose marrow is already predisposed to hematologic cancer. So, but so we have data from the transplant setting and some data that we might need to tailor our risk management for germline carriers. But you might say, well, this really only the best data only comes from transplant outcomes, and maybe you only really need to do this in the setting of transplant or when you have a very high suspicion for hematologic cancer, and that might suggest that we shouldn't screen all patients. Another argument is that when you screen a patient for hereditary hemalignancy, then it has an influence not just on them, but on their family. And we don't have any interventions right now for asymptomatic germline carriers outside of clinical trials. And so this could cause, stress for some patients. I would argue that just becomes an issue of needing to really counsel patients before we test for germline predisposition so that they understand the implications, both for their, management right now and for the future, and give people the choice about, not getting testing if they feel that this is going to be a big issue for them and will cause more harm than good. But, looking forward to the future, we don't have that many interventions right now, especially none outside of clinical trials, really. But how, when we're thinking about developing an intervention for germline genetic variant carriers, what would this be? And so I think that it's pretty clear that what it would have to be is we would have to modify the fitness of CH in germline carriers in order to ultimately prevent them from developing hematologic cancer. So there's kind of a few different ways of thinking about this. One would be to target the specific mutation, like, for example, in RUNX1 patients, to target ASXL1 or BCOR, which we think are enriched in these people and higher risk potentially of causing heme malignancy. Or another example might be where we have a really good targeted therapy would be ivosidenib for IDH1-CH. So the advantage of that is that if you had a really good targeted therapy, theoretically it wouldn't have very many off-target effects, and so would be well tolerated. People could take it over a long period of time. The downside, of course, is that by targeting one clone, you could just lead to the emergence of a different clone and really not influence ultimately the likelihood of them getting cancer. Another potential approach would be to target a pathway important in progression of CH in that germline carrier, like inflammation or something else. The advantage would be that you could potentially prevent multiple clones from expanding and leading to cancer, but presumably there would be more side effects. And we really don't have good examples, honestly, of candidate drugs that would meet this label right now. So we still have a ways to go, just actually even in terms of having drugs that we could use for this approach. But I do think it's very promising. And I think the best data for this idea of intervening early comes from clinical trials of people with CCUS. So these are people that have CH plus low blood counts. And the vast majority of them go on to develop heme malignancy. So they're a very high-risk population, much like some of our germline genetic carriers. And there's a lot of clinical trials right now in individuals with CCUS trying to intervene early. One such example of this is some work that we're doing in IDH1 and 2 mutant CCUS. This is a rare patient population. It's actually only about 1 to 2% of people with CCUS. But the reason why we're interested in it is because IDH1 and 2 have great targeted therapies, ivosidenib and enasidenib. They have good response rates in myeloid malignancies, like 40%, but everyone relapses eventually. And we know that for these targeted therapies, that people that have lower mutational burdens respond better. So it would make sense that if you give it to people that have CH or CCUS, the response rate should be better. So we have a trial in this. Our goal initially was 15 patients. We've actually expanded to 20. We still have open slots if anyone is interested in both the IDH1 and the IDH2 studies. And our main question was just, is there activity of ivosidenib in CCUS? Like, can we resolve these cytopenias? And so the data is really great from this trial. So actually, overall, we've seen 81% of patients have a hematologic response. So the vast majority respond. Most people are still on study and they still have a great response. We've seen in almost all of the individuals normalization of their blood counts, even over a year now of follow-up, still like most patients have complete normalization of their cytopenias. And we even see that we're decreasing the mutation burden of the IDH1 mutation over time in most patients. So, I think this approach is very promising. I think this is going to be the future for trials in germline predisposition, targeting CH early and trying to modify the fitness of CH. And so, understanding the natural history of this is just so critical in order to make this work. And I think, we already have great examples of this in CCUS, and we're going to have more studies in germline carriers in the future. And I'm very hopeful that this is going to really revolutionize our care of these patients. So I want to thank just my lab, just really briefly, just Jie Liu, who did the work that I showed previously on germline predisposition to CH, and my funders, and to the Runk Fund Foundation for being such a great educational and research foundation in this important field. So thank you.
Thank you so much, Kelly, Dr. Bolton. Appreciate the wonderful presentation. And I'd like to introduce Kelcy Smith-Simmer, who's a genetic counselor at the University of Wisconsin, who's joining us for a panel discussion, as well as Dr. Sravanti Rangaraju from the University of Alabama. And looking forward to a discussion. Well, we have one question so far, but please, those of you who are listening, feel free to throw your questions into the Q&A and we'll talk through them. So I think there's lots to talk about. The first question is a question as follows. When recommending germline testing for all heme malignancies, Kelly, were you meaning all types of hematologic malignancies, not only MDS and AML and bone marrow failure related hematologic malignancies, but others?
Yeah, I mean, I was, in a way being maybe a little just like pushing the button a little bit, but I actually do, I think it's reasonable to think about testing all people with heme malignancies because for a couple of reasons. First of all, we know that a lot of the genes that predispose to heme malignancies predispose to other types of cancers. So it makes sense, for both the patient and their family to at least consider germline genetic testing, with appropriate counseling, of course. Because I do think as a field, we probably are moving towards the direction of universal germline testing for cancer in general. So I don't see why that would be different for heme malignancies, since it seems like a good proportion of them are associated with a cancer predisposition syndrome.
I mean, I was surprised when you said you found 15% in the UK Biobank alone. Is that correct? It was the UK
Yeah,
Biobank.
yeah, which is
And that's
similar like for other solid tumors, it's
right.
yeah,
That's a database or a cohort of individuals it's small in terms of age, right? Age range, 40 to 60, is that
yeah,
correct?
yeah,
So
yeah.
you're not including pediatrics, you're not including
No,
young adults, you're not including older adults. So my hunch is that it probably is even higher than 15%.
yeah, yeah, definitely. If you include, because I mean, the patients were followed over 20 years, like they could have gotten heme malignancies later in life, but in order to like get into the cohort, they would have, if they did have a pediatric cancer, they would have had to survive long enough to like get there. So there's some bias, there's some survival bias there for sure,
Right.
like you're
Yeah,
saying. Yeah.
absolutely. Kelsey, maybe you can speak a little bit to the counseling and whether you have any concerns. I mean, Kelly kind of presented the debate like, yes, you could universally test, but maybe you wouldn't because you're potentially putting undue stress on families by, giving them this diagnosis should they go pursue genetic testing. What are your thoughts and how do you think about that?
Yeah, I thought Dr. Bolton, you did a really nice job of commenting on that and saying that it would ultimately be kind of presented as a choice to the patient and the family, depending on their interests. So I think as long as, yes, that appropriate kind of pre-test counseling is happening, making sure that patients are aware of the ramifications, positive, negative, or otherwise, kind of going into testing. I personally would also be on board with if patients of any type of cancer wanted to come and seek germline genetic testing, that again, with appropriate pretest consent, that should be an option available to all folks.
Absolutely. I'm just curious, do you have anecdotally, are there a number of families that say, we're not interested? Is it a large proportion or is it I'm just curious in your own practice.
Yeah, in my own practice, I feel like it's a rare occasion where
Okay.
patients may elect not to move forward with testing. I would say that some might need a little more time to make a decision. Maybe they need a consult with other loved ones, friends, other support resources prior to making that decision. But um, I think that the large majority of people that attend the sessions do elect to proceed with testing.
Interesting. All right, thank you. We have another question here. I'm curious to hear your thoughts on offering germline testing for hereditary heme malignancies to a related donor as a first step before testing the proband, as this could prevent delays due to challenges with sample selection with the affected patient and expedite turnaround time for results. Um, who wants to take that one? Who wants to start off? Dr. Sravanti, Dr. Rangaraju, do you want to take that?
Yeah, I can speak a little bit to it, but I think this has come up
Ooh,
for,
now unfortunately your sound is not so good.
all right, can you hear me now?
Yeah, that's better.
Okay, give me 1 second. All right, so yeah, this has come up in the past when we've been in a rush to kind of get patients to transplant. I think one of the big barriers is um, insurance coverage, because it's hard to get the donors tested for germline testing prior to having any kind of established germline mutation that you're targeting, or a person with or establishing that in the patient itself. I think that's one of the biggest barriers that we've encountered in our patients. Even like parallel testing has been challenging to get, but I wonder if that's more of a insurance barrier that is geographical. For us, it's been hard to get it even for patients sometimes. That being said, I think that it would be an efficient use of time, especially if you want to get patients into a transplant within sort of a 2 months of diagnosis or 3 months of diagnosis.
Makes sense. Any other thoughts from you, Kelsey or Dr. Bolton?
Sure, I'll jump in. I agree that this can become a really tricky situation when working with patients and families in these scenarios. And I hope that access becomes improved over time for these folks and families. Labs offering additional testing methods, maybe on DNA extracted directly from a skin punch biopsy at more minimal quantities, for example, so that hopefully we could help alleviate some of the turnaround time with culturing fibroblasts. Granted, those samples may have blood contaminants, but sometimes we have to get kind of tricky or think outside the box in these tricky
Mhm.
scenarios is I guess what I'm trying to say. And maybe taking a sample right after a marrow demonstrates that there's remission for the patient affected to jump more quickly into a turnaround time. But I validate that that can be hard to do.
Not easy. I hear you. Did you have any extra thoughts there, Kelly?
Yeah, I mean, in general, I feel like I've been able to accommodate like pretty quick testing, and I mean I know that yeah, Invitae has Invitae has a heme panel that some people don't love, but they have a really rapid turnaround time. So I feel like it's usually in my practice it's okay. Like I can accommodate it, and it doesn't delay things.
Oh, that's good to hear. Well, so it sounds like it's a little bit of trial and error and see what works and what doesn't work and depend on insurance carriers, et cetera. All right. Another question here. How do you screen CHEK2 and ATM carriers since those genes came up quite frequently, Kelly, in your data set, when there's no evidence of a personal or family history of heme cancers? And I don't know that those are actually regularly on the heme panels either, right?
I mean, no, they're I think they actually are on the Invitae heme panel. I think they are. But they're definitely not on like standard, well, at least ATM is not on standard somatic myeloid panels, which is often how you find like these incidental germline findings. But um, I mean, how I come across ATM or CHEK2 is really in I've seen it in people that have heme malignancies where we do broad testing in them, and then we find um that maybe they have an ATM or a CHEK2 variant, and then we test their family, and we cascade through the family. So I usually don't. It's usually found in the context of people either having a solid tumor or a heme predisposition gene, and then in unaffected family members through cascade testing. It's like the normal route.
Mm-hmm. Yeah. Any thoughts from anyone else on this topic or question?
Yeah, sort of, I mean, similar to that, I've now acquired at least two families with actually CHEK2 mutations and then, have had developed a heme malignancy. The patients came to me after they've had at least one solid tumor diagnosis.
Mhm.
And that's how we identified sort of the proban and then kind of cascade testing for, we've identified family members who are now carriers. So we're sort of following guidelines that we would for, germline CHEK2 mutations, and that's mainly solid tumor focused for, breast, ovarian, all of that, and then prostate in males. And then colon cancer, I think, has come and gone. So, but I'm still offering it to our patients.
Great, thank you. Here's another question. If germline variants increase heme cancer risk via CH, which tends to be an aging phenomenon as well, why do younger individuals with these germline variants also develop cancer? Is there maybe a different process at play in younger individuals that doesn't involve CH, or is CH also involved?
I mean, it seems like CH is involved because you can detect CH in young people with germline predisposition. Um, but when you have these higher penetrant, I guess, germline variants, it seems like maybe it applies a even stronger selective pressure than you might see for CH in like people that have like ATM or CHEK2, which it does seem like it increases the risk, obviously, of CH, but to a lesser extent.
Mhm.
So yeah, I mean, I think it seems like it seems like for even for younger people, CH is occurring in these germline carriers, but and the other thing is that it's different CH genes, I guess, which is another thing maybe to clarify. So like unlike someone who's 70 years old and has a splicing factor mutation, depending on the germline gene, you might not see CH and DNMT3A or TET2 or splicing
Right,
factor genes. It might be a very unique spectrum of genes in those younger carriers.
right. Which makes it much more difficult as we think about monitoring the younger individuals and knowing what genes to be looking for or what variants to be looking for.
Exactly.
Another question about surveillance. Let's see, I think Dr. Bolton mentioned no intervention for asymptomatic germline carriers. Does she typically recommend any type of surveillance monitoring for heme malignancies developing? Oh, I think.
Maybe maybe I'll let the other two panelists jump in.
Yeah, let's listen. Let's hear about your surveillance processes and whether they're different for different germline variants as well.
Kelsey, do you want to take that or you want me to? I feel like I just spoke.
No, go ahead.
So yes, I think it kind of depends on the variant to some degree. I think we know how to surveil some better than others. That being said, it's not specifically, we don't know because we cannot intervene on the heme malignancies part. I think it's just like a baseline bone marrow biopsy that I've been doing. And then, CBCs and kind of monitoring for kind of the development of clonal hematopoiesis every, 6 to 12 months. How is that going to help me intervene early? I don't think we know, but having a baseline bone marrow biopsy sort of helps establish any kind of baseline dysplasia, what their baseline is, so that when you have a subsequent bone marrow biopsy done, you can, you know what you're working with to kind of compare with. That being said, I think some folks will also get annual bone marrow biopsies. That has not been my practice so far. It's more if there's any suspicion of developing cytopenias or an acquisition of a new mutation on peripheral, say NGS, then I would be pushed towards doing another bone marrow biopsy at that point.
Thank you, Dr. Rangaraju. Kelcy, did you want to speak to anything?
Yeah, and I'm not a hematologist, so I'm not the treating or managing provider for these patients, but I work closely with Dr. Jane Cherpek here at UW Health, the University of Wisconsin, and I would say that feels pretty congruent with the patients in our practice. And I think that kind of an ongoing area of research that other institutions are working on is, if we can identify that patients are progressing towards a heme malignancy, are there some of these options to intervene early? Does that mean something like going to a transplant at a lower risk MDS versus a high risk MDS or an AML? But I think some of those things have yet to be determined, is my appreciation.
Yeah, well said, Kelcy. I agree. I mean, I think, and there's also clinical research opportunities, right? We heard Dr. Bolton talk about the IDH1 inhibitor trials, and it looks like they're quite promising, and that's really exciting. So if you were, potentially following someone who was asymptomatic, and then all of a sudden an IDH1 mutation popped up, that individual could have an opportunity to join a clinical trial. And I'll put a plug in for some of the work that's happening at the RUNX1 Research Program. So there are several trials available now for individuals who have a germline RUNX1 mutation and clonal hematopoiesis. They can participate in a low-dose sirolimus trial that's open at MD Anderson, and you can find more information on our website about that. But there's also an imatinib trial at the NIH testing whether imatinib could increase RUNX1 expression in individuals with RUNX1 FPD and hopefully potentially slow. Long term, the goal is to slow the development of hematologic malignancies. So there is ongoing clinical research, and I think that's the case in Shwachman-Diamond syndrome. I think there are opportunities for specific germline predispositions, depending. All right, let me see if there's another. Yes, there's so many questions. My goodness. Okay. Forgive me if we don't get to your question. Let me take the next one. A barrier we routinely run into is sample collection for patients with heme malignancies. It's often difficult for patients to get a skin punch biopsy, and many labs don't have a direct pathway to culture skin fibroblasts. Do you all anticipate this changing soon or have any advice on how to navigate this? This is a question I think we get all the time during these webinars. And I'd love to hear if there's any new novel navigation pathways or I know it's also changing in terms of which labs offer what. So maybe you all could share, who are you using now and why and whether that's been helpful.
So I can start out like, so what I usually do is um if like if the financial concerns are not huge, then I usually do a skin biopsy and culture fibroblasts at WashU. Our pathology group will do that, and then they send the DNA to Invitae. That's usually what I do. But if somebody and honestly, I feel like I don't have a lot of patients that get really big bills from that. But if the financial concerns are a big barrier, then I just do a buccal swab. And I explained that there's a possibility that we could miss something. It could also be a false positive, and then we might have to do further testing. But instead of just like shutting the door, then I offer that as a second option because, life isn't perfect and better to, do something than nothing, I think. So that's usually my workflow. And I don't know, I'd say half the time I end up just doing the buccal, I'd say.
Oh,
Yeah. Because I mean, a lot of our patients is a big financial, concern. There's big financial concerns. They're not wealthy. Yeah.
okay, that's great. That's a great tip. Thoughts from Kelcy or Dr. Rangaraju?
Yeah, I'm pretty lucky in that we have an in-house, semi-in-house process as well. And I know that Dr. Chirpek has worked to train a number of our other providers, other physicians or advanced practice providers in our space, where patients can get skin biopsies done at the time of, say, a bone marrow biopsy, to alleviate another procedure having to come in just for the skin punch. But we also grow or culture the fibroblasts. At a facility kind of up the street from our institution where we get to then retain the sample and send out the extracted DNA from there. But I can again appreciate that that's not always feasible or accessible for a lot of folks that work in this discipline. And I know, again, as you mentioned, Katrine, that all these labs are also constantly changing. Some have access to be able to grow at other labs and bring that DNA in-house. But I am not as up to speed on that, just given our own
Given your
practices.
situation. Got it.
For those who are on the call feeling alone, my institution cannot do skin fibroblast cultures. So we had been sending it to GeneDx. It's been a while since I've had to send one, but I don't think they're going to be doing that anymore. So that's going to be an issue. While we're trying to work on our ability to do them here, I think we've been having to do buccal swabs for a few patients too, or waiting till remission assessment and then kind of going from there. But that's definitely a challenge.
Yeah. Well, interesting that I see a note here from someone saying that Invitae partnered with Greenwood Genetics for culturing, and the price is currently free. So perhaps that would alleviate the concern you were mentioning, Dr. Bolton, about cost. So newsflash, look it up. Check out, it's called, well, Invitae, we probably are familiar with, and then Greenwood Genetics is doing the culturing. So perhaps that's a new option for folks. There's also a question. Well, someone was mentioning that there's, on the Invitae panel, there's no SB Schwachman-Diamond syndrome gene, for example. And I think one of the questions we get a lot is, well, which panel do you use? Because they're not all comprehensive. And so how do you manage that? How do you make a decision on what test to do, to order? Kelcy, do you want to take that?
Sure. Yes, not having access to SVDS can be especially challenging if you're working with children or individuals with young age AML and MDS. And again, you might have to think creatively of which lab to go to get access to sequencing of that gene if that's high up on your differential, if you're noticing pancreatic issues or other characteristic features. I would say we traditionally like to kind of make a much larger kind of custom multi-type cancer panel, including both these kind of traditional solid tumor risk genes, these hematologic malignancy risk genes, because as we've had been talking about with genes like ATM and CHEK2, I think we're starting to realize that there's a lot more overlap between these different silos. They're actually more integrated than we think. So I think we try to ideally find a testing company that's going to offer us the genes that are on the highest end of our differential that allow us for a customizable option that fits well with the patient's personal and family history, and that is ideally accessible financially to patients.
Great, thank you. All right, I realize we're 2 minutes over. How's everyone doing? Is everyone able to take one more question? Take one more question and then we'll close it up. So I see another question about the buccal swab. If you're testing on buccal swab, do you recommend confirmatory testing on fibroblasts for any positive readout? Or I didn't catch that, or only if the lab indicates a need?
Exactly. Yeah, you would want to do confirmatory testing. Yeah, that's exactly right. I guess, an alternative would be, I mean, it's not an alternative for the person, but you could also test the family. And if somebody in the family is positive for that variant, then it's, that's another, like if for some reason you just like couldn't do it. But yeah, you would want to do the confirmatory testing in the fibroblasts.
You get a positive. Makes
Yeah.
sense. All right. Well, I want to thank all of you for being here and being such wonderful expert panelists. And Dr. Bolton, thank you so much for your presentation. And thank you to all of our attendees for joining and for all the great questions. I will go through the questions. I'm sure we weren't able to go through all of them. And if there's something that we didn't get a chance to address, we can send it out in an email with the recording to registrants. So again, thank you and be well. Have a great rest of your day.